Greetings, everyone, and welcome to the Cardiac Network's United virtual conference entitled Health Disparities in Pediatric and Congenital Cardiology, Understudied and Undervalued. Let me begin by saying thank you to all of you for joining us to discuss this very important topic. As we mentioned in the session's title, there is a tremendous opportunity for us today to both do more and to do better. For those of you who haven't met before, my name is Nicholas Madsen. I'm the co-executive director of PAC3 and a cardiologist in Cincinnati, and have the great pleasure of hosting today and introducing you to our fantastic speakers. So I think I went one slide too far, or potentially more. Great. The sort of nuts and bolts of today are we're going to use Q&A in terms of interaction as each of you are joining the sessions. So please feel free to use that. You'll find it in the bottom of your screen. Next slide. So understudied and undervalued. What do we mean by that today? Well, we say it because we think it's true as it comes to the discussion of health disparities in our field. We say it because we think it provides us an opportunity and really a beginning, a shared beginning here today. There are certainly those in our field who have done a great deal, many of which are collected as speakers here today. But for many of the rest of us, again, it just presents an opportunity. And hopefully, as we look back on today from the future, what we'll be able to say is that these statements are no longer true because we as a field will have moved forward in some fashion. So who are the patients that we serve? As those of you joining us here today know that Cardiac Networks United represents several collaboratives within our field, including in that group is PC4 and PAC3 that obviously have targeted the inpatient hospitalized environment. And what you can see is that our patients are diverse. In fact, you'll notice if you're paying close attention to these figures that the sum total is greater than 100% because for many of our patients, there's the opportunity to reflect multiple race and ethnicities as they are documented through our registries. And so we see this as a real opportunity. We certainly have a tremendous amount of data on tens and thousands of patients, and we hope that we will be able to use that data in a meaningful way going forward. I have the distinct honor of introducing you to our speakers today. And so I would like to introduce you to Jamilah Hackworth. Jamilah is here in Cincinnati, an Associate Director of the Office of Academic Affairs and Career Development. Dr. Hackworth develops and implements and evaluates a cadre of faculty career development programs designed to support faculty and trainees in defining and achieving vitality, engagement, and personal and career success. Our keynote today will be provided by Wendy Nembhard. Wendy is the professor and chair of the Department of Epidemiology at the Boozman College of Public Health and the director of the Arkansas Center for Birth Defects Research and Prevention. Dr. Nembhard's research interests are birth defects with particular emphasis on congenital heart defects, fetal and infant mortality, racial and ethnic disparities in perinatal outcomes. Our panelists who will follow our two opening speakers also provide tremendous expertise in this area. They include Allison Parsons, Research Associate, Division of Critical Care Medicine here in Cincinnati, and project lead for the anti-racism team on the collaborative network All Children Thrive. Anita Krishnan, Associate Director of Echo and Advanced Imaging at Children's National in DC. Elisa Faro, who is a research assistant professor of internal medicine at the University of Iowa, as well as Tawana Nishibayashi, who is a parent and founder of Race Equity Solutions, and a member of the Children's Heart Foundation, and meant to say parent of a child with congenital heart disease. And so with that, I will move forward to Jamilah, who will take us from there.
So I would like to start by giving a definition of structural racism. And a lot of times you might hear this referred to as systemic racism or institutionalized racism. I look at these things as much of the same. So a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. It identifies dimensions of our history and culture that have allowed the privileges associated with whiteness and the disadvantages associated with color to endure and adapt over time. So Dr. Kamara Jones has a simpler definition, so I thought I would share this one with you as well. Something for you to think about: access to goods, services, and opportunities by race. And so I wanted to give you a few examples. I couldn't just give definitions without giving examples. So the first example that I want to talk about is redlining. So I don't know how many of you heard about it, but I'm going to give you a quick, summary of redlining, and then it'll get to where we're going to get by the time I get to my last slide. So redlining was a federal program that began back in the New Deal, and it was explicitly designed to increase and segregate America's housing stock. So what happened was individuals from the Homeowners Loan Corporation, as well as the Federal Housing Administration, got together and they created maps of every metropolitan area, and they color-coded these maps. And the color codes basically indicated where it was safe to insure mortgages or unsafe. And so anywhere Black people lived or near where Black people lived, those neighborhoods were color-coded red, which basically meant to appraisers that these neighborhoods were too risky to insure mortgages in. And so at the same time, the Federal Housing Administration had a manual called the Underwriting Manual of the Federal Housing Administration. And I'm going to quote, it said, "Incompatible racial groups should not be permitted to live in the same community." And so basically what this all meant is that loans to credit-worthy African Americans could not be insured. Therefore, they were denied the ability to purchase property. And so then I'll talk a little bit about the impact of that. So as you know, or maybe not, we'll learn after this. Basically, since most middle-class individuals in our country build their wealth based on the equity in their homes, these 20th century racist federal housing policies almost single-handedly created a wealth gap that exists to this day between Black and white people. And I was reading something a while back, just doing some other work, and there's this real estate app called Redfin. They recently said Black families lost at least $212,000 in wealth over the last 40 years because their homes were redlined. And so that's redlining. And then the next thing that I wanted to talk about, I have the picture there, another example of institutionalized or systemic racism was the GI Bill. And so basically the GI Bill was a piece of sweeping legislation that was really designed to help World War II veterans prosper when they came back from the war. And so, there were Black soldiers who fought in segregated units in World War II. So when everybody returned after the war, the two things that the bill had a lot of different things, but the two things that I'll talk about real quick today are guaranteed mortgages and educational training. So educational or vocational training. the system worked together, like politicians and all types, in addition to redlining, to basically make sure that Black veterans were unable to access the benefits in the GI Bill. So primarily when we talk about guaranteed mortgages, they were denied in lots of really horrible ways. Like, for example, they would dishonorably discharge Black soldiers, and then that meant they didn't qualify. And even in some Southern states, the postmasters would refuse to deliver the forms that the Black veterans needed to access the benefits of the GI Bill. So hopefully you're kind of seeing how the system works together to disenfranchise certain individuals. Also on this slide, so we talk about neighborhoods, we talk about the inability to buy property, we talk about how neighborhoods were segregated, and then let's talk about schools. So in this country, another example of systemic racism is how we fund our schools. Schools are funded typically by property taxes, right? So after everything that I've told you about the whole redlining and how these neighborhoods were segregated, neighborhoods that are thriving, the schools are over-resourced. And then what happens to the schools in the neighborhoods that were redlined? They're under-resourced, okay? So that's another example. And then my last example is immigration policy. You know, how we selectively, you know, pick what types of immigrants we want to welcome into the country. And then, you know, typically Black and brown immigrants are not met with such welcome. So those are my examples. And then I have another one, which is pretty interesting. So this basically is a study where researchers created resumes for Black and Asian applicants for entry-level positions. And some of the resumes included things that clearly pointed out their minority status. And I'll just say, you know, like my name is Jamilah, and you probably won't meet another a white person named Jamilah. I haven't. If you do, please email me and let me know. But I'm just saying, so these are some of the things, you know, by our names, you know, people can, you know, pick and, you know, determine whether or not we are, you know, Black or Asian, you know, or another race. So basically they had some that had minority statuses, you know, cues in the resumes, and then they had other ones that were whitened, like the names were changed to, you know, more common names. And you can look at this little chart here. And so non-whitened resumes for Black people, only 10% of them got calls back for interviews. Whereas those same resumes, when they were whitened, 25% got calls back. And the Asian applicants, 11.5% got callbacks with their non-whitened resumes. But once the resumes were whitened, 21% got calls back. So this is just another example. The next definition that I wanted to give is personally mediated racism. Prejudice, differential assumptions about the abilities, motives, intentions of other people according to their race. And so I have some examples here. Just really quick examples of how personally mediated racism plays out in general society. So the first thing is this whole idea of the loss of innocence of our young Black males. You know, they go very quickly from being very cute little children to then somehow there's this transformation where people perceive them to be threats, right? And this happens at a super young age for Black males. And so I have the picture there representing Tamir Rice, who was a young man who was at a park playing with the toy gun, and he was actually murdered by a police officer. Also, another way that this plays out in general society is police being called on Black people for just doing things like living, you know, and I mean, there are a plethora of examples, but I have 15 minutes. So the Starbucks situation is in the top right-hand corner. And you also have Elijah McClain, who's in the bottom left corner, who was called the police. He was walking from the corner store. The police were called on him because he looked sketchy, and he ended up dying in police custody. There's also Breonna Taylor, who's in the bottom right-hand corner, who, when a no-knock warrant was inappropriately served, she was shot to death while sleeping in her home. And then in the middle, there's this dehumanization of African Americans or Black people in our country, where people, are able to really view them as less than human. And so you see this is George Floyd. The officer has his knee on his neck, he's handcuffed, he can't breathe, and he's, casually got his hand in his pocket. So this is another way that this personally mediated racism plays out in general society. And I mean, if we had more time, I could talk to you about a lot more things, microaggressions and different things that your patients, families, and also that your colleagues of color are dealing with. But this is just sort of my quick example. And for those of you who care for patients, if you have unrecognized or undealt with bias, stereotyping, prejudice, it actually can impair decision-making and contribute to differences in the delivery of care that you provide. So now, health disparities. Health disparities are differences in health status between people that are related to social or demographic factors such as age, race, gender, income, or geographic region. And then you have health inequities, which are population level differences in health that are avoidable, unnecessary, unfair, and unjust. These inequities are created when barriers, and I'll give you a definition of these in a second, but that where individuals and communities they're prevented from accessing the conditions that allow them to reach their fullest potential. We can go on. Which are social determinants of health. So basically the circumstances in which people are born, grow up, live, work, and age, and the systems put into place to deal with illness. And these circumstances are shaped by a wider set of forces like economics, social policies, and politics. And next slide. These are the social determinants of health. So this basically is a Kaiser, this is a figure from Kaiser. And so you can see, so if you think back to what I talked about when I talked about redlining, and you look at neighborhood and physical environment, and I talked about schools and funding, and you look at education, food, access to healthy options, these all influence the health outcomes of your patients. Healthcare disparity or inequity is a measurable, systematic, avoidable, and unjust difference in healthcare access, utilization, quality, and outcomes between groups stemming from differences in levels of social, economic, and environmental advantage or disadvantage. And a quick examples on the next slide. So I found this, basically they studied the disparities in pediatric cardiac surgery outcomes by neighborhood. Essentially, the children from the lowest income versus the highest income neighborhoods were more likely to die following cardiac surgery and required more intensive post-op care. And then this is my last one, tokenism. Tokenism is the practice of doing something such as hiring a person who belongs to a minority group only to prevent criticism and give the appearance that people are treated fairly. And all I have to say about this is that it's great that we're going to diversify our faculties and staff, but we have to do more than just hire underrepresented minorities. We need to create supportive workplaces where people of color feel valued, connected, and respected. Last slide. This is an example that I came across recently, and I thought it was a great, this is an article that was published in the Journal of the American Heart Association, and it had basically the central purpose to argue against affirmative action, and then also went so far as to say that Black and Hispanic trainees in medicine were less qualified than whites and Asians. I appreciate the walk back that occurred when this article was retracted. It was extremely racist and does not, in my opinion, exactly contribute to an environment where your Black colleagues feel valued, connected, and respected. And I just say, when we know better, we have to do better. And with that, I'm finished.
Thank you, Jamilah. Powerful words. We will now move forward with Dr. Wendy Nembhard. Go ahead, Wendy.
Well, thank you, Jamilah, for going through all of those definitions and for the wonderful preface to what I'd like to talk with you today. I have no conflicts of interest to disclose at this time. And so I'm just going to briefly talk about a framework for which we can talk about racial ethnic disparities, how the framework and the disparities apply to congenital heart defects, and then what are the next steps. So when we talk about disparities and we talk about congenital heart defects, I want to just first start about what actually is health. We use this word often, but we don't actually stop and think about, well, what does that mean? And health is a state of complete physical, social, and mental well-being. It's not merely not being sick or not being diseased. It is complete physical, social, and mental well-being. And so if you think about this, that's a tall order. And it's influenced, as Jamilah mentioned, by social, economic, environmental factors, and its individual behaviors and biology, as well as the context of the communities in which we live. So when we talk about equality and equity, Jamilah talked at length about that. A lot of people think that what we're trying to achieve is equality, and that's on the left here, where everybody has the same thing. So our goal is to try to make sure that everyone has equal access, everybody has the same treatment, everybody has the same everything, and that's equality, which is good, but it's not helpful. If you look at this individual in the purple, they have the same, but they still can't see. So how has that benefited them? What we want is equity, where we use the resources that we have to help the people who don't have the resources they need to achieve the same goal, which is everybody seeing over the fence. So we can do the equality model and feel very proud of ourselves that everybody has the same, so therefore work is done. But really, it takes a lot more difficulty and it's a lot more thoughtful to figure out what does the person in the purple need to actually have the same experience that the gentleman and the little boy in the blue and the red shirts have, and that is that person needs 2 boxes, not just 1. So in this framework that is proposed by the National Institute on Minority Health and Health Disparities, I think this is really helpful for our talk today and also in the future when we talk about interventions. So across the top, we have levels of influence because health disparities, racial and ethnic disparities is a huge topic and it can feel overwhelming. So if we think about it, there's an individual level, there's interpersonal, which would be a family or an organizational level, there's the community, and then there's society at large. And across the left are domains of influence. There's biological issues, there's behavioral, there's a physical and built environment, there's a socio-cultural and environment, and then there's a healthcare system. And then across the bottom, you can see that there's the outcomes that we're hoping to achieve, whether that's an individual child, the family unit that we're hoping to improve their overall health, the health of the community, or the population in general. So all children with congenital heart defects. And this spans the life course from pre-pregnancy all the way until senior citizen age. So this framework is really helpful because it addresses the complexity and the multifaceted nature of health disparities, and it addresses the cumulative and interactive effects of the multiple determinants that go into creating disparities and the things that we will need to do in order to eliminate those disparities or reduce them. So first domain is biological, and you can see that the factors here are many. So we'll talk just briefly about a few of them. I need far more time than the time I've allotted to go into all of these in depth. So we're just gonna briefly touch on a few examples. So in terms of genetics, we know that there are many genetic causes of congenital heart defects. And so for example, we have trisomy 18 and trisomy 13. First of all, these syndromes are not distributed equally in the general population. The prevalence of these conditions vary by race and ethnicity. So Blacks and whites and American Indian Alaskan Natives have different occurrences of trisomy 18, 13, and you can think of other syndromes and other similar type things, which means that the distribution of congenital heart defects in these groups will differ because these syndromes differ by race and ethnicity as well. So we know this, we think about it every day, but the impact means that from birth, or even we can talk about pregnancy, the impact of congenital heart defects and the genetic factors that go with that are not equally distributed by race. So there are going to be conditions that affect Blacks and whites differently than Hispanics or Asians. And so when you're talking about the complexities of syndromes, the clinical interventions, the cost, the health outcomes, the impact on society, it's not equally distributed. There are populations by race that are impacted more greatly than others. And same is true for mortality, and we've known this for many years, that in congenital heart defects, race and ethnicity determines what your mortality experience is going to be. This is a slide that shows data from a recent publication, 2020, from Kayla Lopez and colleagues. She updated a study that my colleagues did using national death certificate data, and they looked at all causes of death and then deaths that were related specifically to congenital heart defects. And you can see that this top line here, which is blue, shows the Black-white mortality disparity that has been consistent from 1999 through 2017, and it's a 2.5-fold increased all-cause mortality rate. And then if you look at it specifically for congenital heart defects, it's actually increased over time from 1.28 all the way up to 1.5. And if you look at it for Hispanics, you can see that all-cause mortality is much different picture for Hispanics versus whites. And then if you look at the disparities for congenital heart disease specifically, it's much less. It's 1.13, and for Blacks versus whites, it's 1.5. So there is a disparity that is seen for Blacks versus whites with congenital heart defects, and this is for infant mortality rates. And data shows that across the lifespan, whether it's during the teen years, later in adulthood, the disparity for mortality persists between Blacks and whites, and it lessens for Hispanics over time for age. If you look at a cohort effect and you take a group of babies who are born today and you're going to follow them over time to see what their mortality rates are going to be, you'll see that for Black children, you're going to find that if they're born with a congenital heart defect, they're going to have a lower survival rate than children who are white with a congenital heart defect. This is specifically for pulmonary valve atresia without VSD. But our data showed that this pattern was very similar for most of the major phenotypes. And then Hispanics had the middle survival. So whether you're looking at cross-sectional data or cohort data, and you can account for all of the mortality over time, whether it's in hospital or out of hospital, we do see racial and ethnic differences in mortality. The good news is that, as you all know, survival has improved over time for everyone. And now there are more adults living with congenital heart defects than there are children. And this is a publication that I had the good fortune to participate in. Suzanne Gilboa and our team was able to estimate that there were 1.44 million adults living with congenital heart defects today. But the challenge is that survival is not is good for everyone, but that also poses considerable issues in general for children, adults, and adolescents living with congenital heart defects. That means that they have greater opportunity for morbidity over time. We know neurodevelopmental deficits. They have increased risk of obesity, increased risk of cardiovascular diseases, and other mortality events. And based on research in other areas, we can safely assume that this is not going to be equitably distributed by race in the population. We also know that there will be issues for adults living with congenital heart defects in terms of access to care, which I'll show you in just a moment. So in terms of neurocognitive deficits, this is from a paper that was published in 2019 by the group in Australia, and they were describing the manifestations of neurodevelopmental deficits in children with congenital heart defects and also across the life spectrum. And many of you are very familiar with this, that the impact on long-term outcomes include educational achievement, job attainment, employability, and independence. And the neurocognitive deficits are found in up to 50% of children with congenital heart defects, and they can be quite severe and affect, can range in terms of severity from being very mild, where you can intervene very early with school interventions, all the way to very severe, which significantly impacts their ability to function. One common area of deficit seems to be executive function. And Calderon and Bellinger hypothesized in 2015 that this impact on executive function might be one of the reasons why patients with congenital heart defects have such a high loss to follow-up, because they may have an inability to self-organize and manage medical recommendations long-term. And so this is a possibility. So if we think about the fact that people with congenital heart defects may have deficits with executive function, and early intervention can mitigate those effects throughout their life. Differential access to diagnosis, treatment, and long-term adherence will impact not only early childhood experiences, but throughout the life course. Why am I not showing you data about racial and ethnic disparities in developmental deficits? It's because we don't have any to show you. This is a huge area, a huge gap in the literature where we just haven't looked to see if there are disparities by race and ethnicity in diagnosis, in treatment, in access, in outcomes, in adherence. And we know from in other parts of the literature, such as autism, ADHD, and other neurodevelopmental deficit type outcomes, that there are racial ethnic disparities. It's been well documented that minority populations have lower diagnosis rates, lower access, lower treatment, lower adherence. So there's no reason to believe that among the population with congenital heart defects, it would be any different. In fact, it might be even more magnified. So if we talk about another area, which is, I'm flying through this, is mental health. We know that 30 to 40% of young adults with complex or cyanotic CHDs will have depression or anxiety. In adulthood, that is still seen, where lifetime prevalence is 24 and 38%. We know that access to diagnosis for mental health, treatment, adherence, again, the same issues that I described with neurodevelopmental deficits is even more highlighted for mental health issues. And again, I have no data to show you about racial ethnic disparities here, because this is another huge gap in the literature. We just do not know what the current does a prevalence differ by race and ethnicity? Are there access issues? Are there treatment issues? And we can only extrapolate from the general literature, which has shown that for persons with mental health issues in general, there are racial and ethnic disparities. And so we can assume or presume that these racial and ethnic disparities are present in the population for congenital heart defects as well. So another domain is behavioral, and this is where we get issues, for example, parental stress, so parents of children with congenital heart defects, resilience, coping mechanisms. These are very important things for the family. Again, I have no data to show you about racial ethnic disparities. We know it's an important issue, but the work has just not been done, because we do not know how families in minority populations cope differently. What are the risk factors for divorce? What are the risk factors for problems and issues in the household? We know that minority families are more likely to be single parent households than majority families. So all these issues are things that need to be addressed, that have not been even considered in the CHD literature. The physical and built environment is also a very important topic. We know that where you live matters. And Jim Kuchik and I did a study, and as well as Shane Morris and I, we looked at neighborhood and socioeconomic status and how it impacts mortality in children with congenital heart defects. We were able to demonstrate that those children living in the most disadvantaged neighborhoods had the lowest survival rates compared to those living in more advantaged neighborhoods. The distance from the cardiac center for repair, we know that has an impact. So it increased the mortality rate. So all of these things, access to care for if you are an adult living with a congenital heart defect, where you live matters. So you can see that in the country, there are deserts where there are no adult congenital heart defect specialists. And so geographical context makes a huge difference in terms of your outcomes. Sociocultural environment, acculturation, literacy and language issues. So we also did a study looking at the effect of acculturation, and we did see that there was an effect in terms of first-year survival in infants with severe congenital heart defects. Literacy and language, if your first language is not English, how well are you understanding the information that your healthcare provider is giving you? Health literacy is a problem even among English-speaking adults. And if we think about the fact that adults and adolescents with congenital heart defects may have neurodevelopmental deficits, may have mental health issues, and now we're communicating with them about complex medical health issues, how well are they understanding that information? How well are they able to make informed decisions about their health care if we just spew out information assuming that everybody understands equally? There's often issues with provider to provider care, coordination of care, and if your language, if you have cognitive deficits as a result of having a congenital heart defect and you have a language other than English as your first language, you can see that this is a recipe for a lot of misunderstanding, a lot of difficulty. So again, this is where racial and ethnic disparities can arise. And then healthcare system, access to and quality of care issues. I can show you lots and lots of data about Hispanics, Blacks, and other minorities having difficulty accessing care and difficulties accessing quality of care. Delays in care, lack of insurance, they're more likely to be underinsured. So I'm going to just flip through some of these other slides because I want to get to this slide to really talk about, yes, okay, so why do health disparities matter? Why do we care about racial and ethnic disparities other than it's the right thing to do and we all nod our heads? But ultimately, disparities in health, including those in the congenital heart defect population, they determine who lives and who dies, how long they live, the quality of life that they experience when they're alive, and their ability to engage with their environment and society. So it should not matter the color of your skin, the language that you speak, or when you came to this country as to how long you live. It should not matter how well you speak English, the quality of experience you have in the healthcare system. But unfortunately today it does. And so when we try to tackle the issues of racial and ethnic disparities in congenital heart defects, it's overwhelming. Like, where do you begin? You might sit there and think, well, I'm only one person. I'm a physician, I'm a surgeon. My job is to repair hearts. How can I make a difference? Or you might think, well, I work for an NGO, or I'm a parent. This is all overwhelming. How can I change a massive system? And so I go back to this framework, and I would suggest to you, if you think about it in pieces, it's doable. Where do you want to make a change? What is your level of influence? Do you want to intervene at the individual level? Do you want to intervene at the community level? Do you want to intervene at the family level or the organizational level? So think about it in terms of levels of influence. When you go back to your organization or you go back into breakout groups, think about the domains of influence. What are you trying to target? Are you trying to target coping strategies? Are you trying to target Maybe you're more in the genetics part or the biology piece. You're really tackling that prenatal environment with, trying to influence brain development and brain sparing and those types of things. Well, think about where along this domain of influence you're trying to target and at what level you're trying to influence. And then it's not so overwhelming. And then you can think about what is your health outcome? Is it the individual patient? Is it the family? Is it the population in general? And then you can formulate a plan by trying to identify differences among the population, validate if, how, and when those differences lead to health disparities. And if you have identified a disparity, then you can design an intervention to reduce that health disparity. So it's not so overwhelming. It's a 1, 2, 3 step process. And hopefully we will be able to reduce the gaps in the literature and be able to come back next year and say, in my hospital, we have identified differences. We have now identified that there is a disparity and we have taken this action to intervene for that specific hospital. You don't have to take on the entire healthcare system. You can just do it in your hospital, in your clinic, in your practice. It's not overwhelming if you think about it in that context. So I encourage you to look at your sphere. Where are you? Look at the data. If you don't have the data, start collecting it. Do something that's within your power to do. Think about your own biases and assumptions. And so at the end of the day, hopefully in a year from now, we can be talking about equity, not equality. And I want to acknowledge my co-authors, Dr. Jamilah Patel, Dr. Maria Politis, who are postdoctoral fellows in my center, the funders who helped me do some of the research that I presented today. And I want to thank you very much and the organizers for inviting me to talk to you today about a topic I'm passionately involved with and would love to answer some of your questions.
Wendy, thank you very much. We gave you and Jamilah both enormous tasks and very little time to do it in. And I think in general, as mentioned, we think of today as a beginning for Cardiac Networks United and all of us. And thank you very much for helping us get off on such a great start.